Welcome to STEM Talk.
STEM Talk. STEM Talk. STEM Talk. STEM Talk. STEM Talk.
Welcome to STEM Talk, where we introduce you to fascinating people who passionately inhabit the scientific and technical frontiers of our society. Hi, I'm your host, Dawn Carnegas, and joining me to introduce today's podcast is the man behind the curtain, Dr. Ken Ford, IHMC's director and chairman of the Double Secret Selection Committee that selects all the guests to appear on STEM Talk.
Hi, Don. Great to be here. Dr. David Diamond is a professor at the University of South Florida and is also director of the Neuroscience Collaborative program. Although his academic specialty is neuroscience, for the past several years, he has been researching the role of fat and cholesterol in heart disease from a fresh perspective. He and his colleagues have also pointed out the misleading statistics arising from using relative risk versus absolute risk calculations when assessing the efficacy of statin drugs.
But before we get to today's interview with David, we have some housekeeping to take care of. First, we really appreciate all of you who have subscribed to STEM Talk, and we are especially appreciative of all the wonderful 5-star reviews piling up on iTunes. As we announced in several earlier episodes, the Double Secret Selection Committee has been continually and carefully reviewing the iTunes reviews with an eye towards selecting the wittiest and lavishly praise-filled reviews to read on STEM Talk. As always, if you hear your review read on STEM Talk, just contact us at stemtalk@ihmc.us to claim your official STEM Talk t-shirt.
These 5-star reviews really help with STEM Talk's visibility on the iTunes platform, and we greatly appreciate them. Today, our winning review was posted by Fine Arts Dad, entitled Satisfying the Serious Inner Science Geek. The review reads, "Two smart and well-spoken interviewers conversing with interesting experts in various fields of science always draws me back for more. Superbly done, long-form interviews that never fail to keep my attention and wanting for more."
Thank you, Fine Arts Dad, and thank you to all the other STEM Talk listeners who have helped STEM Talk get off to such a great start.
Okay, now on to today's interview with Dr. David Diamond.
Dr. Diamond is a University of South Florida professor in the Department of Psychology's Cognitive, Neural, and Social Division. He is the director of the university's Center for Preclinical and Clinical Research on Post-Traumatic Stress Disorder, as well as the director of the Neuroscience Collaborative program. His research projects at the university have ranged from the effects of stress on brain, memory, and synaptic plasticity to the cognitive and neurobiological perspectives on why parents lose awareness of children in cars.
Following test results that showed his own triglycerides were through the roof, he decided to research the role of cholesterol and fat in heart disease, as well as the effectiveness of statins, a class of drugs doctors prescribe to help lower cholesterol levels in the blood. What he discovered through his research contradicted the low-fat, high-carb diet that he, as well as many other Americans, had been advised to follow. This led Dr. Diamond to develop a graduate and undergraduate seminar entitled Myths and Deception in Medical Research. It also led to a lecture he gave at the university entitled How Bad Science and Big Business Created the Obesity Epidemic.
That lecture, which was recorded and is now a YouTube video with more than 190,000 views, focused on how, quote, flawed and deceptive science demonized saturated fats and created the myth that a low-fat, plant-based diet is good for your health, unquote. Dr. Diamond got his Bachelor of Science and PhD in Biology from the University of California, Irvine. He became an assistant professor in the Department of Pharmacology at the University of Colorado before moving to the University of South Florida in 1997 to become an associate professor.
David has served on federal government study sections and committees evaluating research on the neurobiology of stress and memory, and has authored more than 100 publications, reviews, and book chapters. He is a fellow of the American Institute of Stress, and in 2015 he received the award for outstanding contribution to science from the Riga Diabetes and Obesity World Congress.
STEM Talk. STEM Talk. STEM Talk. STEM Talk.
Hi, this is Dawn Carnegas, your host for STEM Talk, and I'd like to welcome our guest, David Diamond, to the podcast.
Thank you for inviting me.
And joining me today is Ken Ford.
Hi, Don, and hello, David.
So, David, I understand that you've always been interested in science, and even as a kid, you wanted to be a doctor.
That's right. I had a passion for biology from the time I was a child, and really all I knew was if you have an interest in biology, you become a doctor.
Yeah, that makes sense, right?
I played doctor, too. When I was a kid.
I don't want to know about that, Ken. So you majored in biology at the University of California, and then after graduating in 1980, you continued at school to get a PhD in biology with a specialization in behavioral neuroscience. So you also spent time at the university as a postdoctoral researcher at the Center for the Neurobiology of Learning and Memory. Can you talk about your research during those years?
Well, there was a novel approach that we had then in which we actually recorded from single brain cells as animals learned information. And we were able to show that the single cells in the brain of the cat, for example, would actually change its activity as the meaning of a stimulus changed. We could actually monitor that right at the moment that learning was occurring.
That's really fascinating. And so then your research at South Florida has been quite varied, and some of your primary research projects include effects of stress on brain, memory, and synaptic plasticity, treatment for combat veterans and civilians with PTSD, and cognitive and neurobiological perspectives on why parents lose awareness of children in cars. So what led you to start studying forgotten children in cars?
Well, actually, the common thread is memory. So it's really about 40 years now that I've been studying brain and memory. And in Denver, I was at the VA where I got to know people with PTSD, Vietnam vets, and I was studying brain and memory both in people and animals. And not only what fascinated me about memory, but also forgetting. And so traumatized people have these pathologically intense memories, and they're also forgetful. And so I decided that both aspects were important to study, and I actually started writing about forgetting and brain mechanisms involved in forgetting. And then one day, about 12 years ago, a reporter called me and said, "Can you explain to me how these parents are forgetting kids in cars?" And it was just out of the blue. And actually, it's a combination that I've wanted to become involved in this to help parents not to leave kids in cars. And scientifically, it's fascinating to me.
That's interesting. With such an extensive background in memory and PTSD research, what led you into studying cardiovascular disease and statins?
Well, I have to say, even though understanding PTSD and heart disease, the two are very linked, people with PTSD do have more heart disease. It actually wasn't a scientific approach that led me to study cardiovascular disease and statins. It was really quite personal. About 10 years ago, I had extremely abnormal cholesterol levels and triglyceride. I was also quite a bit heavier than I am now. So this really was personal for me. I wanted to learn about cardiovascular disease to understand why I was at such high risk for developing heart disease.
So, David, as a result of your research, you also ended up creating a class about distortions that we've been told about public health, which also led to a lecture that you gave at South Florida that was entitled How Bad Science and Big Business Created the Obesity Epidemic. Actually, from what I understand, it's now a YouTube video with over 190,000 views. What inspired you to do this class and lecture?
Well, as I said, 10 years ago, I decided for myself that I needed to learn about heart disease. And whether I really was at high risk for heart disease, what I should do about it. So I started reading a few papers, and before I knew it, I had read a few thousand papers. And I was taken by the literature that indicated actually that these statins that I'd heard about, that my doctor insisted I be on, were so incredibly ineffective. And that overall they have such a small effect on outcome and coronary activity, coronary events. And the more I learned, frankly, the more angry I became, and I wanted to share this information, and I started a class. And I was very pleased that this is now an honors class at the University of South Florida, in which we cover, in part, heart disease and other diseases as well, in which I feel people have been misled, primarily by drug company-sponsored research. Well, the students actually then proposed that I give this talk. It's called Dinner with a Scholar. And USF sponsors this once a year for one professor to give a talk to the public. So in that talk, I summarized what I had learned really about diet and heart disease and the deception in the field.
And then everybody catches on. It's been a pretty hot topic from what I understand.
Well, it was my first talk that I gave, which is online. I've given about half a dozen or so since then. And I've actually then been invited to speak at conferences, cardiology conferences, diabetes conferences. And so I've also given grand rounds lectures to physicians. So I've had an opportunity to share this information that I've learned with the public and physicians.
That's great that you're getting to the medical community too. You and a colleague actually published a recent paper that makes the point that statins have failed to substantially improve cardiovascular outcomes. I find it really interesting that so many doctors do prescribe this drug.
Well, the point of the paper was how basically pharmaceuticals have manipulated the data to make it appear as if the statins are wonder drugs, when frankly they are incredibly ineffective. Mm-hmm. The point we made in the paper was that the papers have emphasized what's called relative risk. And the relative risk enables you to take an incredibly small effect, and it amplifies it. And I think the problem is that most doctors aren't aware of how the data have been manipulated to make it appear as if the statins are far more effective than they really are.
And then what about additional risks? What kind of additional risks are we seeing with statin use?
Well, that was what we covered in the paper as well. And so what you find is a very broad range of side effects from the statin use. The most prominent, the most obvious one is you find that healthy people put on statins have a significant increase in the rate of diabetes. And it's not trivial. What you'll find is that people naturally, in these studies given placebo, you'll have about 5% of people that develop diabetes. And this is almost twice as much. 10% or so of the people on the statins will develop diabetes. And this has been found repeatedly in different studies. So this is a common side effect, but it's been well documented that you have numerous other side effects, such as cataracts, erectile dysfunction, the muscle and joint pain that comes from atrophy of the muscles. And I will be covering that in my talk a bit, but there are numerous side effects published in peer-reviewed medical journals that I would say the pharmaceuticals prefer to ignore.
So can you loop back and talk a little bit about relative risk versus absolute risk calculations? That's worth drilling in on a little because there's a lot of confusion around that.
Yeah, thanks, Ken, because I think that is a very important point. So if you have a clinical trial, which you just have 100 people given placebo, 100 people given a drug, and what you find is, let's say, 2 out of the 100 in the placebo have a heart attack. 98 have no adverse events whatsoever. And then what you have in the drug-treated group, 1 person has a heart attack. So 99 people have no adverse event. So understand we're working with very small numbers. Only 2% had the heart attack in the placebo group. 1% had the heart attack in the drug-treated group. So the real difference in terms of how many people benefit from the drug versus the placebo is 1%. 1 out of every 100 people would actually benefit from it. Now, what you can do is take that number and distort it. The difference is 1 out of 2. And so going from 2 heart attacks to 1 heart attack is a 50% reduction in heart attacks. Mm. So the question now is, if you are the pharmaceutical, which number will you use when you want to advertise your drug? Will you tell people there's a 1% difference from placebo or a 50% difference? And that 50% is what's called the relative risk. The 1% is the absolute risk. And so the absolute risk actually is reported in the papers. The relative risk, though, is emphasized in the abstract and in the news reports and in the ads for the drug.
Mm-hmm. Using that for media purposes.
That's right. And that's often the only thing doctors will see at these conferences, typically sponsored by the drug companies, is they will see the relative risk reported without the absolute risk reported.
Mm-hmm. So are there any ongoing trials looking at the degree of cholesterol lowering and clinical outcome using absolute risk statistics?
Well, I think it's important to recognize that it's not that they are not reporting absolute risk. Every study reports absolute risk in the results section. And currently it's going on. You will see this 1% reduction in risk of coronary events. The question is now, where is that reported and how is it reported? In the discussion section, typically they're talking about a 50% reduction in coronary events. The summary, quite often, which is really, frankly, where most people don't get beyond, the doctors will read the summary, and there they will see a 50% reduction in risk. So understand, they are being scientifically accurate by always providing absolute risk data. But when it is that they want to promote the drug, they use the relative risk data.
So we have two interwoven stories here, one of possible statistical deception in describing the putative benefits of statins, and the other related by a separate issue of whether there are instances where it may make sense for physicians to prescribe statins. Are there any subsets of patients that you would recommend treating with statins? And what about patients with familial hypercholesterolemia?
So first, I want to emphasize I make no recommendations.
Right.
I'm a scientist and I provide information, and then people make decisions for themselves. What I have done is studied familial hypercholesterolemia. And so what you have is people who have a mutation in their LDL receptor, and the end result is elevated levels of cholesterol. This so-called disease has been demonized. It has been made into a disease. I think it's actually very important to understand that people with this so-called disease actually have a normal lifespan. The fact that a small subset of these people do develop heart disease, and some it's quite young. You'll see children develop heart disease who have familial hypercholesterolemia. But the vast majority of people who have extremely high cholesterol are incredibly healthy, and they live normal lifespans. And the reason why I say this is I'm currently writing a manuscript with some of my co-authors who I've worked with before, and we have reviewed the entire literature on hypercholesterolemia. And what we have found are dozens of papers actually showing good health in people who have extremely high cholesterol, 2, 3, 4 times normal levels. So what I'm saying is, in a subset of these people, you do see heart attacks, but the vast majority of these people do not suffer from heart disease at a young age.
That's interesting. So are there any other subgroups where use of statins might be defensible?
So I think the problem and the basis of your question is the assumption that LDL somehow is inherently atherogenic, which means there's just something about the LDL packaging of cholesterol that causes heart disease. And what I'm saying is that's entirely wrong. There is no level of LDL that is unhealthy. There is no level of LDL that should be treated with a statin. Now, I've just reviewed the literature, for example, on the hypercholesterolemia, and I found, and I'm working with Ufi Ravenskov and some other authors, and we found 20 trials in which you have people with phenomenally high LDL, and they have absolutely no heart disease. And it's statistically equivalent to those with heart disease. So my primary point that I like to make is that this is an artificial distinction about LDL being inherently toxic, cardiotoxic. It is not LDL that is causing heart disease. So there is no one that I think should be on a statin to reduce LDL because, in fact, people with very high LDL can be incredibly healthy.
Yeah, for example, we know that elevated LDL seems to be very common in the population of people who consume a very high-fat, strict ketogenic diet, and otherwise their health markers and overall status are really good.
That's true. Some people respond to a ketogenic diet with an increase in LDL. My LDL actually increased when I went to low-carb, higher-fat diet. And in fact, we published a paper just recently. I work with a phenomenal group of clinician scientists, published it in British Medical Journal, in which we showed that, frankly, people of my age, people 60 years and older, those with the highest LDL actually lived as long and even longer than those with low LDL. And so we know, in fact, that the people with high LDL actually have lower rates of cancer and lower rates of infectious disease. So we need to understand that high LDL is not something that's inherently toxic. High LDL is actually important for good health. So I'm completely against the idea that LDL itself causes heart disease.
Cholesterol has been so demonized that a lot of people probably aren't aware that our bodies need cholesterol to synthesize the naturally occurring steroids in our systems. We would cease to exist without cholesterol. Can you give us an overview of the role that cholesterol plays in our bodies?
Yeah, it's a great point that you've just made, that cholesterol is absolutely necessary for good health. It's necessary to be alive. Cholesterol is the substrate for every sex steroid. It's a substrate for vitamin D. The brain needs cholesterol to be able to make new neurons, new synapses, for the brain to function and make new memories. People have this perception of cholesterol basically being formed for the sole reason to clog our arteries. And that's why it's there. And that's such a misunderstanding. It's a misrepresentation of the importance of cholesterol for good health.
So you had previously mentioned people with low LDL. What are some of the dangers of low LDL?
Well, the important thing is to look at the studies and look at the health of people with low LDL. And so these are correlational studies. And what they consistently show is a dramatic increase in the rate of certain diseases, such as cancer.
Mm-hmm.
You find a much higher rate of cancer in people with very low LDL. And I'm not talking extremely LDL. In fact, some people have trivialized this as if, well, you have cancer, you're about to die, your cholesterol drops. What you find is if you look at cholesterol levels and then follow people for 10, 20, even 30 years later, those who have the lowest cholesterol, naturally low cholesterol, are more likely to die at a younger age. They're much more likely to develop cancer and infectious diseases. Mm. So I think it's just important to understand that cholesterol is an essential molecule of health. And the idea that cholesterol is inherently unhealthy, I'm emphasizing this is something that has been created by very bad science going back over decades.
Mm-hmm.
An often overlooked aspect of lipoproteins in general is their role in the innate immune system. Mm-hmm. Of particular note, both HDL and LDL particles can help to reduce the toxic effects of lipopolysaccharide, which is the main irritant in systemic sepsis. Given all of this, should we perhaps, and should the medical community, look at lipoproteins from a bit broader of a perspective than simply as lipid shuttles and a source of cardiovascular disease risk?
So I think what's very important about your question is to recognize that LDL is a part of the immune system. And so when there is damage to an artery, what you then have is susceptibility then to infection. And you do find evidence of pathogens that are present in plaques. So what's happening when the artery wall is damaged, especially from the inside, and there is atrophy inside the artery wall, you then have an infusion of white blood cells as well as the LDL, which work together to kill the bacteria, and that promotes inflammation. And so in this sense, LDL is really just like an innocent bystander. It is used then to attack the pathogen. It is used so that the artery can be repaired, but it is not there in order to initiate the damage.
So from the research that you've been doing, what actually causes heart disease, and what can people do to reduce a heart attack?
So I just said that there is atrophy in the artery wall, and that is, in a sense, is part of the trigger. So I think what's so important to emphasize is that why is it that the artery wall becomes damaged? And so a critical trigger factor is the coagulation. Mm-hmm. And what people don't realize is our blood can clot without us being wounded. When we are stressed, or if someone smokes, or if you have high blood sugar, that actually triggers clotting mechanisms. And so we actually have these tiny arteries inside the artery wall called the vasa vasorum. And these tiny arteries have to feed the inside of the artery. And they are basically can be considered to be easily blocked or clogged by these clots. Now, when the artery wall is not fed sufficient blood through the vasa vasorum, it becomes hypoxic and that tissue dies. And when that tissue dies, it needs to then have the cholesterol come in, the LDL, the white blood cells come in. And in a sense, it's really like a scab. And when that happens repeatedly, that artery wall gets thicker and thicker. And so people think that the inside of the artery becomes clogged with cholesterol. That's not what happens at all. It is the inside of the artery wall that atrophies and is repeatedly repaired till that wall gets thicker and thicker and thicker until eventually it chokes off the blood from flowing through. And the final coup de grace is, again, if someone has an extremely emotional experience or high blood sugar and high blood pressure, that produces the clots. And that clot will then pass through someone's artery until they come into a narrowed artery and it closes it off, and then you've got a heart attack. None of this has to do with LDL causing heart disease. So if you're asking ultimately what really matters is you want to keep your clotting factors inactive until they're really needed. And most of the time, since most people are not going to hemorrhage in their lives, you really don't need to have those clotting factors always on alert. So it is the smoking and the stress and being sedentary, not exercising, that contributes ultimately to the heart disease.
So what types of diet or exercise approaches would be optimal for improving cardiovascular health?
Well, what I have learned, and it just shows how 10 years ago when I had my very low HDL, I had very high triglycerides. What I've learned is not to use a pharmaceutical approach to be able to deal with abnormal lipids. And the reason being is these biomarkers are just indicating that there is something off in the metabolism. My extremely low HDL, my extremely high triglycerides, I could have taken medication which would have changed my HDL and triglycerides. But I learned actually that it was my chronically high blood sugar. It was the bread and the potatoes that I was eating, and frankly, a lot of sugar. I thought as long as I had bread and I didn't put butter on it, then it was healthy.
Quite the opposite.
It's quite the opposite.
Hold the bread.
It's hold the bread, eat the butter.
Eat the butter.
So I think that really the starting point that I've learned is that it's that increase in blood sugar that's happening so often. It starts right with breakfast when people have cereal and orange juice and toast. So you're leaving the breakfast table with a whopping increase in blood sugar, which is then followed by a dramatic increase in insulin. And so now your body's responding to this incredible change in your physiology. The alternative, far better way to approach this is to have a very low carbohydrate meal. Mm-hmm. And it's interesting that it's been demonized, and you talk about having meat, which is basically extremely low carbohydrate, no carbohydrate. And so you don't see this big rise in blood sugar. You don't see the big increase in insulin. And so that's really the way to normalize these biomarkers. And so once I learned that and I cut back on carbohydrates, my HDL rose, my triglycerides dropped by 75%, far better than what happened with any drug. And it's really a natural way to be able to normalize biomarkers. So my first recommendation is absolutely reduce carbohydrates in the diet, and not just a little bit, reduce it a lot. As far as exercise, I enjoy a good aerobic workout, but 10 years ago when I was overweight and my markers were all wrong, I was exercising like crazy. Aerobic exercise, tennis, and I just kept gaining weight. And the real problem was I was exercising, but I was also drinking Gatorade. Then I'd go back and I'd have a muffin.
Oh, boy.
But I figured as long as I'm not eating fat, I'm okay.
When you were probably jogging. Eat bacon, don't jog.
Jogging
My friend Grant Peterson has this hilarious book out. It's actually really good. And the title is Eat Bacon, Don't Jog. You should check it out.
Everybody would jump on that. Yeah.
That's a great title. Very appealing. Well, I was along with everyone else thinking every time I had bacon, I'd be standing on that cardiovascular cliff. Of course, I'm about to die, but it tastes so good, I'm willing to give up my life to be able to eat bacon. And now I recognize that that's far superior to eating carbohydrates.
Yeah.
And bacon's better for you than a glass of orange juice. Surprise, surprise.
So it's kind of talking about fats in our diet. Specific fats like arachidonic acid are thought to be pro-inflammatory, and they're found in high concentrations in things like animal meat and egg yolks. Does overconsuming this particular fat represent a health hazard? This is part of a problem, I believe, in the misrepresentation of food. And I also think it's partly a misunderstanding of when we're talking about inflammation. The first thing is look at people who consume lots of eggs, lots of fat. Whether you're looking just at populations such as the Inuit in North America, and you're looking at the Sami in Scandinavia, who eat lots of fat from animals, a very high fat diet, marine animals, and fish. And you don't see the inflammatory diseases in these people. The Maasai in Africa, who live off of cow meat and milk and blood, you don't see these kind of health problems in these people. So I think inflammation, in a sense, has been overstated as to its importance, because ultimately, again, it gets back to the carbohydrates. In the healthy people, what you find in general are moderate to low carbohydrate consumption, or at the very least, what you got is higher percentage of calories from fat relative to the carbohydrates. So I think it's important to recognize what triggers the inflammation rather than focusing on the inflammation itself. Mm-hmm. And we know actually that increased blood sugar and stress
and pathogen exposure will trigger the inflammation. So we should stop focusing so much on reducing the inflammation, and I suggest we reduce the causes of the inflammation.
It's a great answer. So what is the ideal ratio of omega-6 to omega-3 in our diets, and do you think that this is important?
Well, I want to emphasize that I'm not a nutritionist, and so I don't want to come across as being an expert specifically in all these aspects. But I think what we need to understand is the omega-3 is coming from, in particular, fish is a great source of omega-3. And so you see the healthiest people are eating lots of fish. And so I think it is in part related to the omega-3. Of course, the omega-3 is reducing clotting activation. And so I think one of the real benefits of the omega-3 fatty acids is a reduction of coagulation, and that contributes then to a lower rate of heart disease. We have to recognize where the omega-6 might be coming from. And so you get omega-6 fatty acids perhaps from vegetable oil. And so you might feel good about getting it from corn oil, but I don't think that's not found to be healthy at all. And so I don't think it ultimately gets down to saying, well, a 1-to-1 ratio of omega-6 to omega-3 is probably pretty good, because that way you don't have, you have sufficient coagulation. So, the Eskimos probably had too much omega-3, not enough omega-6, and so they tended to bleed too much and they could die of bleeding disorder. And so I guess cautiously what I'm saying is we have to have balance in our diet, but we have to avoid certain foods that are unhealthy, such as certain vegetable oils.
Right. So we've kind of talked about your diet, personal diet, and exercise routine. What else do you incorporate into your personal health regimen, such as do you do any supplements or fasting?
Over the years, I've tried supplements. And it always seemed to me that you have a supplement because you have some concerns about your health. You don't have enough energy. I remember 10 years ago, I could barely play a set of tennis. And I was so exhausted, and frankly, I was fat, and I just didn't have much energy. It was an embarrassment. I remember playing some guy who was 30 years older than me, and he wasn't winded, and I was. So, of course, what did I want to do? I want to go out and get a supplement, go have some, ginger or garlic supplement and give me more energy. And again, it gets down to what's really the best thing for you to be healthy. I've seen the research. I've seen, for example, on the curcumin, and people love how it's an anti-inflammatory. Well, again, what I emphasize is focus on a lifestyle that reduces the inflammation itself, reduces the cause of the inflammation. So at this point in my life, I've pretty much stopped taking all supplements.
Reflecting on the reaction to your research and lectures, what kind of pushback have you received? It would seem like you might get some.
Well, I have been invited to speak at cardiology conferences. And I have to say, I think at first the cardiologists at these meetings are completely aghast at what I say. They're totally surprised. What they see, they've never expected. And I don't think they're ready to respond to me at these meetings. Now, I did get a very strong response once because in a podcast, I was explaining why it was people shouldn't be on statins. And there was a cardiologist at Duke University that wrote an op-ed that said that my views were dangerous. She was very concerned that her patients, as a result of listening to my perspective, stopped taking their statins, which she said then put them in peril because now they're more likely to have a heart attack. I wrote a response to her op-ed, and it's at my homepage, in which I explained how wrong she was about everything, how she greatly overstated the benefits of statins in her op-ed. I sent my rebuttal to her op-ed to her, and I certainly recommended that she contact me if she would like to learn more about heart disease. But I didn't receive a response from her.
Imagine my surprise. STEM Talk is an educational service of the Florida Institute for Human and Machine Cognition, a not-for-profit research lab pioneering groundbreaking technologies aimed at leveraging and extending human cognition, perception, locomotion, and resilience.
So, the London Daily Telegram ran a story last year on how a group of international experts, including yourself, claim that cholesterol does not cause heart disease in the elderly and that trying to reduce it with drugs like statins is a waste of time. The story also pointed out that these experts' claims drew immediate skepticism from other academics. So how do you think the public deals with conflicting messages like this?
Well, first, that is a paper that I wrote with about a dozen other clinician scientists, published in a high-quality, peer-reviewed journal. I believe that was British Medical Journal. So it went through rigorous review before it was published. The findings were absolutely crystal clear. No one has been able to say that our findings weren't accurate. We reviewed every paper on LDL levels and longevity and health. And what we found was consistently that people with the highest LDL lived as long and even longer compared to people with low LDL, followed over decades. And what people haven't liked about that is we basically said in the paper, why would you want to lower your LDL if it means having high LDL indicates you're going to live longer? And so there have been criticisms of that paper simply because they don't like the results, but there have been no substantive criticisms of that paper. I will say that the public is probably confused. They are getting very strong messages from both sides. From the group I work with, we're trying to show them the findings in which LDL has not been found to be directly causal to heart disease. But what you have are people very well funded by Big Pharma who have come out against that view. And they have been publishing reviews which are clearly very biased. They're very deceptive in how they are cherry-picking data and studies to be able to support their point, heavily dependent on the use of relative risk to amplify the trivial effects of cholesterol lowering with statins. And so I am actually in the process now in which I'm working with the group to come up with a rebuttal to the Big Pharma group, which has been promoting the statins and is basically saying that we are wrong in talking about LDL not having adverse effects.
Assuming that your analysis is essentially correct, do you have any thoughts on how, given the scientific method and the peer review process, errors this large and pervasive continue to persist?
Boy, that's a great question, and it's tough to come up with an answer that doesn't just say that the journals appear to be in bed with Big Pharma. The journals that seem to be most amenable to the individuals paid by Big Pharma and promoting Big Pharma are not the journals that have been amenable to our submission of the manuscripts for publication. So I think there's a great bias in the journals potentially being influenced by Big Pharma itself.
We do not often see stories like this in professions such as engineering, perhaps. What is it about medical research that amends itself to this process?
Well, one thing, especially when talking about heart disease, is that it's not obvious as the atherosclerotic process is developing, and it's something people are worried about, and it's very different from thinking about in engineering, you want to be able to design a structure that won't fall over. And so, it becomes a much more physical strategy that you have to follow. But when it comes to heart disease, you worry, is that day coming? And you're looking for an answer from medication. And so I think that's where people are really vulnerable, that they want to believe that by taking a pill, they are less likely to have heart disease. And it works with other diseases as well. We want to believe that having a vaccination of some kind or take another pill, and we'll be less likely to have cancer. So you can name the disease, and this is something that hangs over our heads. We're so worried about having this disease, we want to be able to take something. Now, as well, once someone has the disease, I've talked to people who are so terribly frightened because someone has had a heart attack. And so they don't want that to happen again. So they become very susceptible to what they're being told in the ads and by their cardiologist. And so it's very different from thinking of us as a machine. We're biological organisms, and we want to be able to optimize our survival and health. And if we can do that with a pill, well, then we're very amenable to it.
The question was really aimed at the profession, not at the patient. So as, a person on the street, one assumes the bridge won't fall over when they drive over the bridge. The question was sort of focused on the professional standards. There seems to be a lot of emotional argument And there wouldn't be an issue like relative risk. Can you imagine applying relative risk to aircraft safety or bridge safety?
Yeah, I guess what you get to is the profits have been absolutely phenomenal beyond belief.
Mm-hmm.
Lipitor itself generated over $100 billion in revenue. And then what you have is big pharma, which pays very well to people in authority and then influences their decision making. And then they go out, and then doctors basically are not scientists. They come to trust the people in authority. And so the doctors then follow these people in authority. And so ultimately, I guess one has to be really cynical about this, saying it's the profits of big business that are basically having a terrible influence on people's health decisions.
And the docs have very prescribed standards of care that they're expected to follow.
Yeah, I look at it that the doctors are in a tough position.
Agreed.
And they, obviously we have very bright people, but they're not trained to evaluate the methods, nor do they seem terribly interested in scouring the journals to find, well, is it relative risk or absolute risk? And they, as you say, they do feel the pressure to follow the standard of care. So if you have an individual with high LDL and other markers of heart disease, if that doctor decides not to prescribe the statin based on perhaps something he's heard from me or something he's read, the doctor is now vulnerable potentially to a lawsuit. So they have to take that into consideration when they're making their decisions for diagnosis and treatment. Absolutely.
They are indeed in a tough place. Recent evidence suggests that the atherogenic risk correlates pretty well with inflammation. Are perhaps the reported benefits of statins associated with the recently touted anti-inflammatory properties rather than primarily their cholesterol-lowering effects?
Yeah, I think, first of all, any benefits from statins have absolutely nothing to do with cholesterol. So we really need to get that across, because there were decades of studies before the statins came around in which you could lower cholesterol substantially. And it had a trivial effect on coronary outcomes. Going back to the time of, you can use corn oil. Corn oil truly does lower cholesterol levels dramatically. And I'll actually be talking about that today. You lower someone's cholesterol with corn oil, and those people actually had more heart attacks with lower cholesterol. So lower cholesterol is not a successful outcome if the patient dies. Yes, statins do have slight anti-inflammatory and anticoagulant activity. And that may explain why you have a relatively minuscule benefit there. This 1% always seems to persist in these statin studies. But again, what's called number needed to treat. How many people do you need to give a statin to before you'll actually have a reduction of one heart attack? And typically, you're looking at between 100 and 200 people have to be treated to be able to reduce one heart attack in that one person. So really, we're talking about very minor effects if you're relating the statin effect to anti-inflammatories. I mean, let's just imagine that antibiotics were as ineffective as statins. I mean, with this 1% benefit, meaning imagine 100 people all have an infection, and you're giving 100 people the antibiotics, and only one person gets better. Mm-hmm. I mean, that would be a total failure. But with statins, we call them wonder drugs.
So kind of going back to society, many people today think that they can find good health in a pill. They think that there's some pill or an herb or something that's out there that can cure them. Is that your experience?
Right. This was actually the way I was thinking 10 years ago, as I talked before about how I had no energy, lethargic. I was gaining weight. And so, of course, we look for pills to be able to help us to lose weight. We look for herbs, supplements. And, almost all of this work really has been done on cell cultures, it's been done on animals. There's almost no real success with these pills, whether you're talking about herbs, supplements, or medication. So what I emphasize to people is there's just simply no substitute for having a good weight, being active, keeping your blood sugar low, and exercising.
Yeah, back to the basics.
That's the simple basics, is what we were designed to do.
Yeah. So you've studied the historical perspectives of medicine, and you've talked about how in the past people didn't trust medicine that much, but that seems to be different today. Can you expand on why you think that is?
I think there was a dramatic change in the way people think about medicine following World War II, when you had development of vaccines, particularly the polio vaccine, and antibiotics. So two highly successful interventions, which basically told us that medicine could actually make us healthier as a result of illness with antibiotics, and medicine in advance, a treatment in advance, could keep us from getting a disease such as polio. And I think this got people thinking, well, now we need to find other medications to render us immune from other diseases. And so that's where the big pharma suddenly was able to get so much support from people, because we want to have these drugs that could be as effective as antibiotics and a polio vaccine. And so when you're looking at heart disease, people are looking for that equivalent drug. And so I think there's an entire mindset that developed after World War II, which is the search for drugs to eliminate disease. And I think in general, that has failed.
So when people have an illness or some kind of biomarker that seems wrong, they immediately want to tackle that specific symptom instead of kind of looking at what's causing that. Do you think this is the right approach?
Yeah, again, I think the mistake is to target the biomarker of the disease rather than the cause of the disease itself. I mean, just think about it. You have an infection, you have an increase in white blood cells. Well, that's a biomarker of infection. Why not take a drug that'll kill white blood cells?
Right.
I mean, the white blood cells are right there, and they're always there whenever you get sick. So kill off the white blood cells. And so the biomarkers to me are an indicator of lifestyle. They're an indicator that there is a disease process undergoing. It doesn't mean that the biomarkers are causing the disease. So what I learned to do is, rather than take medication to raise my HDL, which, by the way, these drugs have been around for, now almost 20 years. I could have been on one of those drugs that would have raised my HDL. HDL being the good cholesterol you want, because you want it to be high, higher HDL associated with less heart disease. Well, these drugs have been around for almost 20 years. You can take a drug that'll raise your HDL, and it was shown almost 20 years ago that that drug killed people. And so there was a drug called torcetrapib, which increased HDL, decreased LDL. It was supposed to be the next billion-dollar blockbuster. And who knows about torcetrapib now? Nobody.
Nope.
Published in New England Journal of Medicine, torcetrapib killed people and caused more heart disease. So these people were dying with higher HDL and lower LDL. They should have had ideal biomarkers. So what I'm saying is the biomarker is really a marker of lifestyle. Mm-hmm. If you're obese and sedentary and eating lots of crap, there is no pill that will reverse that bad lifestyle.
Mm-hmm.
Is there any evidence that prescribing statins changes people's perception of their risk of cardiovascular disease and thereby changes their behavior in ways that actually might increase their risk? For example, not exercising. I saw a guy, he was wolfing down a giant steak. And his friend said, "Hey, I thought you had high cholesterol." And the guy said, "Get away from me. I'm on Lipitor, dude. I'm eating this bad boy."
I have heard the anecdotes. I have heard people say that they feel immune from having a heart attack because they're on a statin. I haven't seen impressive published work actually showing that happens. There's a slight difference in weight gain in people who are on statins versus not statins. But I think part of it is people may very well be less likely to exercise, and this is a known, well-established fact, that there is more pain, more muscle pain when people exercise when they're on statins. So in fact, may be counterproductive because people will not want to exercise because they're feeling this muscle and joint pain from the statins. But as far as explicitly, is there widespread sense that now I can eat all the candy and ice cream and even steak that I want because I'm on a statin? No, I haven't actually seen published findings on that, but it certainly makes intuitive sense.
What would you recommend to patients when their physician says, "I'm going to prescribe you statins"?
It is so difficult to go against doctors' advice. I remember my doctor urged me to go on a statin. And even with a PhD in biology, it was very difficult for me to say no to him.
Yeah.
The cardiologist is seen really as the one who's got all the best information So the layperson is really has a great disadvantage. And so if they listen to me and they listen to others say, well, the statin really isn't of much benefit, then they go back to the doctor and then they'll say, well, this guy's wrong. So I do think it's a very difficult situation for someone to be able to know what to do. I've tried to make my presentations as straightforward as possible for a layperson, and I do find once they see that relative risk is so amplified compared to the real risk, I think people come away from that saying that, no, they're not interested in taking the statins anymore. So I guess the emphasis has to be first, people have to take charge of their bodies. I tell people, your doctor doesn't tell you what medication to take. You are in charge of your body. You decide what medication you're going to take. And if the doctor won't accept that, well, then maybe you find another doctor.
Yep. Absolutely. So from what I understand, the literature is a little bit mixed on this, but what are your thoughts on the effects of statins for exercise performance and muscle strength, and in particular as it relates to the aging population, which are already a population that are most widely prescribed these drugs?
There is very clear evidence that statins interfere with muscle function. And you see this with athletes. This has been shown a couple of times in the papers I've seen. There is just no doubt that what's happening is the statins have interfered with metabolism. I mean, bottom line is you really need to think about a statin as a toxin. It is interfering with our metabolism. It ultimately causes a breakdown of muscle tissue, which then that breakdown of muscle tissue, now you've got excess proteins, which can be interfering with kidney function, and you do see impaired kidney function, people with statins. So I think when people start to realize that statins are poisons, that they're not so beneficial, they're interfering with muscle function, they're interfering with brain function, that they'll have to think about, well, why do I want to keep taking this when the benefits are so trivial and the adverse effects are so well described?
So there seems to be a recent trend to take low doses of a statin drug 2 to 3 times per week, coupled with Zetia. Research at Johns Hopkins published in the Annals of Internal Medicine recently compared the benefits and harms of a lower intensity statin when combined with one of several other cholesterol-lowering treatments in adults at high risk for heart disease. And in that study, they found that combining a low-dose statin with either a so-called bile acid sequestrant or Zetia seemed to be as effective at improving the standard biomarkers as a high-dose statin alone. The authors went on to say that this approach might be particularly beneficial to many patients who experience undesirable effects when on statins. Perhaps, as with many things, and as noted by Paracelsus many years ago, the poison is in the dose. What are your thoughts on that?
See, the first point here is the obsession with LDL basically causing heart disease. So what we've got to do is get LDL down without causing the poisonous effects of the statins. And that's fundamentally flawed. And so the first is we've got to eliminate this obsession with trying to get LDL down at any cost. The second idea is, well, what we got to do is eliminate inflammation. I think we need to understand inflammation is actually a beneficial thing. It is a way for the immune system to attack an invading pathogen and also to respond to damaged tissue. So I'm actually not so amenable to the idea of, well, we've just got to reduce inflammation. Inflammation is triggered by something. And so what we want to do is reduce whatever it is triggering the inflammation. And again, it's the high sugar. It's being obese. It's being stressed. That's what contributes then to excess inflammation. So I'm saying the hard thing is to look at the trigger for the inflammation. Now, ultimately, though, this is fantasy. The idea is we're recognizing that statins have adverse effects. So the fantasy is that what we can do is lower the dose to the point that there won't be adverse effects and we'll only get benefits. Well, how do we know that? What if by lowering the dose, we'll ultimately only have adverse effects and no benefits? And so, again, I think what they're trying to do is save the statins by lowering the dose to the point at which we'll only have the benefits. And I find there's no evidence to say that the low-dose statins provide actual benefit to real coronary events.
Yeah. So, we talk about precision medicine a lot recently, and are there studies that integrate genetic testing prior to administration of statins? I'm wondering if there's some people who might actually benefit from statins over other people.
I have seen some of the studies. I have not looked in depth at those studies. And I think, again, this is a way to save the statins because what the recognition is that for most people, statins basically don't work. And especially in women who develop heart disease very late. I mean, there's almost no evidence of benefit to women. And most of the studies are done on men in their 50s. And in fact, the reason why statins actually are not recommended for people over 75 is you find that people have extremely high cholesterol are far healthier when they're over 75. And there's been never any benefit shown in giving statins to people over the age of 75. Well, that doesn't make any sense at all. If LDL is clogging arteries, why does it stop doing that as soon as you turn 75?
Right.
I mean, if you got something inherently blocking arteries, you would think the older you get, the more likely it is the high cholesterol should be killing you. And in fact, the opposite is happening. And so that really tells us there's something completely different involved. So I think this genetic testing is basically trying to find that incredibly small subset of people that will still be willing to buy their statins. But ultimately, I think this is just a desperate industry trying to save the statins from extinction.
So in your publication, you talked about the Ascot LLA study, of which the results have been promoted extensively through advertising, and which was stopped prematurely due to what researchers called impressive results in reduction of cardiovascular heart disease and fatal myocardial infarction. Can you talk more about what the numbers of the study actually demonstrate and why they actually terminated the study early?
That was one of the early statin studies using Lipitor in people who had high blood pressure. So they combined either the Lipitor or Lipitor with an antihypertensive. And so this is a great example of how relative risk was used to promote the sale of these drugs. So when you look at the ad for the Ascot LLA study, what you find is they're talking about a 36% reduction in cardiac events, which sounds huge. I mean, can you imagine you've reduced your chance by a third of having a heart attack? You're going to feel pretty good about that. But this is one of those studies where you have a minuscule effect. So after a few years of treatment with the Lipitor, again, the difference is just 1%. What you had was about 98% of the people on Lipitor of the placebo did not have a heart attack. 99% did not have a heart attack. You're down to a 1% difference. And what's fantastic, and I'm showing this in my talk today, I'm going to show the Ascot Lipitor ad, which actually shows a 36% reduction, but in fine print at the bottom of the ad also shows the 1% reduction.
And you see something similar with the Jupiter study that you talked about in your publication as well. Can you expand on that a little bit?
The Jupiter study was used Crestor in relatively healthy people. And the real problem with healthy people, they just didn't comply. They just failed to get heart attacks. They were just too damn healthy.
Uncooperative.
Did not cooperate with the researchers at all. And they were looking to be able to find statin benefits to the people who are relatively healthy. And you have some numbers that are just microscopic that were inflated in that study. For example, you can have 0.7% of the people who had a heart attack on placebo versus 0.4%. I mean, incredibly trivial numbers. But again, think about it. Reducing from 0.7 to 0.4 is a near 50% improvement. And that is what they did with the Jupiter study. To me, there's just something offensive about that.
Yeah, absolutely.
A very new paper by Manzi et al. This paper just came out, and it has the title, Statins for Primary Prevention in Physically Active Individuals. Do the Risks Outweigh the Benefits? And it was published in the Journal of Science in Medicine and Sport. This paper examined the potential benefits and adverse events of statins among physically fit individuals. In particular, they looked at the associations of statin use with beneficial cardiovascular outcomes and adverse effects in active duty military personnel. They apparently mistakenly think that's a stand-in for fitness. The authors conclude that among the healthy, physically active individuals, statin use was associated with doubling the odds of diabetes and diabetic complications without countervailing cardiovascular benefits. Do you have any comments on this paper and its findings?
So thanks for actually sharing that paper with me, Ken. First, I want to take this opportunity to compliment Manzi, who is doing some outstanding work. And you can see that he is one of the few researchers who is not funded by Big Pharma. He is at a VA, and he has been showing adverse effects of veterans who use the statins compared to non-statin approaches. He's found other side effects as well, increased cataracts in people on statins. So first of all, it's a high-quality work that's coming out of his lab. It's not tainted at all by the influence of Big Pharma, and you're seeing some real, profound adverse effects of the statins. And in this case, when we're talking about doubling of diabetes, we're not talking about going from 1% to 2%. What we're finding is, according to Manzi's work and others, that the rate of diabetes in the control group might be 5%, and then you're looking at 10% in those taking the statins. And that's huge. When you're talking about millions of people that are taking the statins, 5% will now develop diabetes and have a trivial benefit from a cardiovascular approach.
And ironically, diabetes is associated with heart disease.
Yeah, I actually contacted one of the authors once, and it was actually supported by Big Pharma. And I said that we're looking at statins actually increasing diabetes. Aren't you concerned about that? And he said, well, actually, that will put them at greater risk for heart disease, and that's why they need to take their statins.
Yeah, we had a previous guest on STEM Talk that played guitar on an album called Pretzel Logic. And I think
that would be Pretzel Logic.
That is exactly Pretzel Logic.
As we've discussed, you've done a lot of research into statins, but I understand that there's a new category of drugs coming on the scene with the unlovely name so far, PCSK9, and that you're looking into these. Can you talk a little bit about this?
So this is a new generation of drug with a very different mechanism than statins to be able to reduce cholesterol, and specifically LDL cholesterol. So PCSK9 is an enzyme that causes a degradation of the LDL receptor after it binds the LDL. So the way it goes, LDL binds to the receptor brings the LDL into the cell, and then the receptor disappears as a result of PCSK9 activation. Well, these drugs block the PCSK9 from causing a deterioration of the receptor. So instead of disappearing, that receptor comes back to the surface and stays there. And the end result is now you've dramatically increased the density and the number of LDL receptors. When you have more receptors, they're going to bind to more LDL, and so they'll take the LDL out of the blood and then bring it into the cells. And the beautiful thing about this from the approach of Big Pharma is that now you've got a way to lower blood cholesterol, and everybody feels great about it. And it has a huge effect. It'll lower LDL by 50%. And so now you've got the LDL that's so low, and everyone's so excited about this new drug. And two things about this, though. The first is that LDL isn't disappearing. We have to realize what this means is you're now cramming that cholesterol into the cells. You're making those cells chock full of cholesterol. And so you've taken a natural adaptation, negative feedback to get that PCSK9 system to work. And so the LDL receptor disappears. Everything is in balance. Now you've taken everything out of balance. And so these cells become bloated with cholesterol. But the doctors are happy about it. The patients are happy about it because now there's no cholesterol in their blood. Well, the only study that has come out, one study just came out about a month ago in New England Journal of Medicine. And this has been promoted as a phenomenal effect. LDL was reduced by over 50% in these people treated with a drug, which is also called Repatha. The difference, again, from placebo is 1%. So you eliminate almost all LDL from someone's body, and then you reduce coronary events in these people by about 1%. And so, again, it's a minuscule benefit which has been amplified using the relative risk, because then they say they don't say 1% in the ads. They will say it's a 20 to 30% reduction in coronary events. But the actual effect of this drug is trivial. And I feel rather confident that when they look at long-term studies, we're looking at some serious diseases that will result as a result of this treatment.
Well, Sharon, if you lower LDL too much, the negative effects are pleiotropic. I mean, our sex hormones and much else is made out of cholesterol.
Absolutely. So you're looking at susceptibility to diseases such as cancer. And I mentioned erectile dysfunction associated with lower cholesterol, less testosterone, less estrogen. So ultimately, we're looking at serious harm caused by this drug category.
That might be what's happened to society.
That explains a lot.
It explains quite a bit. Though you've been really critical of big pharma, your neuroscience research also has been funded by drug companies. Can you talk a little bit about that?
I am not just personally against the use of medication. I'm not against big pharma being involved in high-quality research, such as my neuroscience research, which potentially can help people. I'm involved in drug development to be able to help people who have PTSD. So I'm in no way against drug development, and I'm certainly amenable. The drug companies would still like to talk to me. I'm amenable to the possibility of receiving funding. I have an NIH grant, actually, in which we are working on drug development to help people with PTSD. So I believe there is a place for medication to help people's quality of life and potentially prolong life. I just haven't been convinced when we're looking at the cardiovascular drugs that they have been of any benefit to us.
That's a nice explanation.
David, in addition to science, what interests do you pursue now outside of science?
Well, I hate to say this, but I don't know, maybe I'll sound shallow. But I begin my day and I read heart disease. I read papers on heart disease. Then I read studies on the brain. Then I read papers on parents forgetting kids in cars, and I become actively involved in that. And then the next day is the same. I have my passion. I do have a passion for racquetball and other forms of exercise. But I have such a passion. I enjoy so much learning about the various diseases, learning about the heart disease. I'm trying to write these papers on heart disease as well as writing the papers and doing my neuroscience research. That's as much as anyone really can handle.
Yeah, well, your passion definitely comes through, and I really want to thank you so much for joining us today.
This was great fun, David. Thank you.
Well, thank you so much for inviting me.
STEM Talk.
STEM Talk.
STEM Talk.
STEM Talk. STEM Talk.
Wow, this interview with David was very timely given the number of articles that I've been seeing published recently, and they've all been talking about the lack of benefits of statins and also the potential risks that are associated with them. So it's really good that there are people like David out there who are getting this information out to the public.
David's relatively recent foray into nutrition, cholesterol, and statin drugs have certainly attracted attention, both positive and negative. While one can imagine reasonable people coming to different conclusions regarding the benefit-risk ratio of statin drugs, it's hard to feel good about what seems like statistical deception in the way the drug companies have characterized their utility.
Agreed.
As Benjamin Disraeli, a prominent 19th century British politician and writer who twice served as Prime Minister of the United Kingdom, is, according to Mark Twain, reputed to have quipped, "There are three kinds of lies: lies, damn lies, and statistics." Interestingly, the evidence that Disraeli ever actually said this is somewhat sketchy, but nonetheless, the point is made.
If you enjoyed this interview as much as we did, I invite you to visit the STEM Talk webpage where you can find the show notes for this and other episodes, stemtalk.us. This is Dawn Carnegie signing off for now.
And this is Ken Ford saying goodbye until we meet again on STEM Talk.
Thank you for listening to STEM Talk. We want this podcast to be discovered by others, so please take a minute to go to iTunes to rate the podcast and perhaps even write a review. More information about this and other episodes can be found at our website, stemtalk.us. There, you can also find more information about the guests we interview.